Hi, everyone. Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation. And today we have a special treat. Dr. Padraic O'Malley is with us with UF Health. He's a urologist. Welcome, doctor. How are you?
Good, thank you. Happy to be here.
Great, and we're happy to have you. And today it's been a topic that a lot of people have asked us to cover, which is, after a diagnosis, what questions should you be asking your doctor? So Dr. O'Malley has put together a PowerPoint for us to go through, and at the end, we're going to have a Q&A session. So please feel free to type in your questions into the chat, or just save them until we get to the Q&A session at the end, and we'll be happy to get your questions answered before the end of the call today. So thank you, everyone, for joining us, and please take us away, Doctor.
All right. Thank you very much for having me again. I'm just going to share this and make sure this, yeah, all right. So I tried to keep the talk a little on the shorter side just because, the questions you ask may vary from person to person, right? We're all individuals, and when it comes to your disease, we're all individuals as well. So some questions that may be pertinent for one person may not be for another. So I've tried to leave plenty of time at the end so that we can talk about that if you have a particular interest in one sort of scenario versus another. So we'll get started. I really don't have any disclosures except for the fact that I'm on the board of directors with the Judy Nicholson Foundation. And I've really enjoyed my work with them. Here at home at UF Health, I'm an assistant professor in urology. I'm actually the chief of the division of urological oncology, and I'm also I do a fair bit of robotics myself, but I'm also the assistant chair for the robotics program at the university itself. So that's a bit about me, no disclosures. So let's get into the sort of real meat and the question. What are the questions you want to ask when you go see your physician to get the most out of your visit? And that's going to set you up for success. And that's basically what we're going to talk about today. And there's a couple things that we'll sort of broach when we talk about the questions and why these are important questions. And we'll see, one, we'll talk about, renal mass versus kidney cancer. Is there a difference? And when is that likely to be important? We'll talk about different disease states, right? Not everyone has a small mass, not everyone has a big mass. There is a spectrum. So we'll talk a little bit about those who are sort of more localized, small renal mass versus those who have, unfortunately have a larger mass and it's also spread somewhere else. So we'll try and cover a bit of both of those scenarios and in between, and talk about how that then impacts what the treatment options may be for you. So just a little bit of background on kidney cancer. Most of you are probably familiar with this. There's about 82,000 new cases of kidney cancer expected within this year. It's a very common cancer, both for men and women. It is more common in men than women, but in both cases, in both genders and sex, it's actually one of the top 10 most common cancers for both men and women. And the other thing about kidney cancer is that it continues to rise. So this is a nice chart. It's actually from the UK. But we see this in the UK, in the US, in Canada, in France, and Germany, that kidney cancer is something that actually continues to rise. Now, initially, we thought that was because, well, we image people a lot more, people get the CAT scans a lot more, but even when you account for that, it is still on the rise, and we're not sure why that is. So, this is going to become a bigger and bigger problem over time as we have more and more people who are affected by this disease. Again, in the UK, for instance, that rate has increased over 88% since the 1990s, and similar in the US. The average age of diagnosis for most patients with kidney cancer is in the mid-60s, but we certainly see a broad spectrum. So, in patients who don't have sort of what we'd call pediatric cancers, I've seen someone as young as 18 or 19 with a kidney cancer. It's pretty shocking. And I've seen people obviously as old as in their 90s with kidney cancer. So it definitely runs a broad spectrum, but the majority of people are around the mid-60s when diagnosed. Most kidney cancer is what's called clear cell renal cell carcinoma. And so renal basically means kidney. So renal cell is basically a cancer of the kidney cells. And clear cell is the most common sort of variant. There are a number of other variants, okay? You can get clear cell, papillary, chromophobe, renal medullary, and so these are out there, but they are less common. And they have their own nuances that are important for us to know, and maybe important for you, depending on which one of these you fall into. The other thing that's important to note is that, when you hear someone has a small renal mass, that doesn't mean it's kidney cancer necessarily. You can have cysts, which are benign, and then you can have solid lesions, and I've given you a whole list of those here, right? These are all, they sound bad, like oncocytoma, rhabdomyoma. They may sound bad, but they're actually all benign lesions, those ones. So you can get a fair number of kidney tumors or masses in your kidney which are not cancerous. And that's important because, not everything needs something done about it. And that's our job to tease that out a bit and to help you sort of tease that out. So I think the first two questions that are probably most important for patients across all the spectrum of the disease is, one is, how do I educate myself? How do I learn what's going on with my body and my health? And where do I go to get seen? Where do I find the right doctor to take care of me, to help me navigate this health issue and make sure I have a good outcome? And, how do I educate myself? I think if you're here, you're probably already answering this and you're on the right path. These sort of types of sessions can be very educational for people and are a good source of information. Organizations such as the American Cancer Society and obviously the Judy Nicholson Foundation, most of these organizations are also great places for information. And there's different types of information, right? There's information about what your kidney normally does, what kidney cancer is, and what we look at. But also, there's also the opportunity where you can also talk to other patients who may have had kidney cancer. We as physicians, I deal with kidney cancer every day, but I've never had it myself. And so, there are things I can tell you about it, a lot I can tell you about it, but there are some things I can't. Only someone who's walked in your shoes can. And so sometimes that's beneficial. But, these disease-specific patient groups like Judy Nicholson Foundation, I think, are a great source of information and resource for patients. So I think that's the first step to start to begin to educate yourself, is to look for this information. And nowadays, most of that is online. The second question is, where do I get seen? And it comes down really to two factors. There's one of our pancreatic surgeons here. He's a little grayer than I am. Very experienced, very good surgeon. And he always says you need to have expertise and experience. If you don't have expertise, you better have experience. It's a combination of things, right? You have to have that knowledge base as a physician to understand about kidney masses and kidney tumors and how they behave and how to treat them. You then have to have the skill set as a surgeon to go in and be able to do that. And you also have to have the expertise to have that group of people around you and that are part of your team. Because, like I said, not everyone fits into these little boxes. And some of those boxes require more than one type of treatment. So you can't do it all as a surgeon. You may need a surgeon, you need a radiologist, a pathologist, a nurse navigator. You need a radiation oncologist, a medical oncologist. And so you need to have those expertise, that team around you. The second thing is experience. If you're seeing a doctor who sees one kidney cancer a year, it's probably not going to have the best and most robust information or discussion with you about what your options are. They just, it's a volume thing, right? They don't see that enough. We see this on a daily basis, so we feel pretty comfortable dealing with it, right? We see patients with small renal masses. We see patients with metastatic kidney cancer. So we see patients in all those pockets all the time. In many places, there are centers that do that. The one problem is I find that it is inherently difficult for patients to know or how to discover where those centers are, right? So, if you go on to the US News, right, they've got US News Health and stuff like this. They've got, best hospitals for this, best hospitals for that. I will tell you that information, it's a good attempt to try and give patients some information on what places metrics are, but it has many pitfalls. And so, we're one of the top ranked 50 places in the country. Does that mean we're really in the top 50? I think it does, but those metrics they measure at US Health News may not be the ones that'll actually pertain to you doing better when you see a physician at those centers. So it's a bit difficult. I think if you go to organizations like Judy Nichols Foundation, kidney cancer awareness groups, you can find out the centers in your region that are high volume that do a lot of this, right? So Florida, myself, I do, a lot. So University of Florida, we also have Mayo Jacksonville, we also have Moffitt, Miami, all those centers in Florida are excellent. But it's just sometimes hard to tease out where to go for this. So then you get into sort of the nitty gritty, and that's sort of when you see a surgeon and, what information do you want to know? And it's kind of like, well, you've got a mass in your kidney. So the question is it small, medium, or large, right? And that gives you a number of pieces of information. One, it gives you the likelihood of cancer. If you've got a very large mass, the likelihood of it being cancer is much lower. It's never zero. I took out a kidney out of a lady that was about 2/3 of a meter, so about 2 feet in size, and it was not cancerous, right? But I kind of knew that ahead of time. But that's rare. Most times, if you have a mass that big, it is cancerous. But when you get small masses, the chance of them actually being benign is actually much higher. So the information you get from asking small, medium, large is, is it likely to be cancer? The larger it is, the more likely it's aggressive, and the grade, i.e. it's a higher grade, more aggressive biologically, it goes up, right? So when you ask small, medium, large, small tumors tend to be more indolent or lazy. You get up to large, they tend to be more aggressive. And ultimately what that does is it tells you, well, what are you going to need to treat your kidney mass? What is the management options for your disease? So it's a very simple question. It's just basically how big is it? And that will start off to give you the information that you're going to need to know which is the best way to manage this. So as I mentioned, small renal masses, these are ones that we consider less than 4 centimeters. They can be, like I said, benign or malignant. And the growth isn't always indicative of that. Okay, so these most times go very slowly. Some can grow very fast. That doesn't mean they're cancerous. It could, but it doesn't necessarily mean that. But these make up 40% of newly diagnosed renal tumors. So it's a large portion of patients who have mass in their kidneys are actually small renal masses. 20 to 25% of these are actually benign. So a quarter of these are actually benign. So, if we go in and take that mass out of every single person who walks in the office, we're going to be over-treating, 1 out of 4 people, which is, a massive over-treatment. Generally speaking, these grow very slowly. So they grow about 0.1 to 0.2 centimeters a year. So if you've got a 2-centimeter tumor, it's probably been there more than a year. It's probably been there for a few years, but it's not going to get rapidly bigger in most scenarios. And most of these, even if they are cancerous, are actually what we call indolent or essentially lazy. It's not like, we've all heard about people who say have a pancreatic cancer and it's kind of here today, gone tomorrow. These are not that scenario. These are the types of things that, some older patients, you could live with it and it would never lead to a shortening of your lifespan. Okay. The risk of it spreading generally is quite low. It's probably, 2 to 5%, maybe lower than that. So the chance of these small masses actually going and spreading somewhere else in the future is actually extremely low. If you did nothing, the chance that 5 years on, you are not dead from this mass is almost 100%. So these are not things that you have to rush to have removed, next week. They're the things that you need to take time to consider what your options are, depending on what your age is, what your medical issues are, and what things, as far as treatment options, may interest you. You've got time to make a decision that's informed and that's suitable for you as an individual. These are a bunch of publications, and they basically support all this information. So one thing that we as urologists have been guilty of is sort of saying, well, you should just take it out. And that's well and good for me as a surgeon. I like operating, right? And it's easier just to do it and be done with it, and then I don't have to worry about it. But it doesn't mean it's the best thing for you as a patient. So, some people say, well, these are almost always cancerous. That's not true. And, here's a list of 10 studies that demonstrate that, right? Or, oh, these could grow or they could spread. Well, the risk really is negligible. And here's the data, here's the papers that show that. So, you know, if anyone sort of says, oh, you need to have this taken out right away, there is a multitude of studies in the literature that support not jumping in and doing something next week. Okay, you've got time to think about your disease. You move on up then from the small to sort of the medium and large. These tend to be sort of larger masses, and as mentioned, because of that, probably more aggressive. And generally speaking, those are greater than 7 centimeters with either they haven't spread elsewhere, or if they have, it's only a minimal amount. But these are really a ticking time bomb, right? These are the ones that you don't want to sit on this for 6 months, because if you give it time, it will do bad things to you. It is a very mixed group of patients, okay? I'll show you 2 tumors that technically are kind of in the same stage, but I can tell you one person's going to do better than the other person. And when you look at the images, you will probably be able to tell which one's going to do worse as well. If you look at how well these patients do, 5 years out from treatments, how many of them are cancer-free after surgery, it's a broad range. It's 35 to 85%. So if you were in that 85%, you're like, well, that's pretty good. If you're looking for 35%, you'd say that's not good. And so it's a broad spectrum because it's a wide spectrum of disease type of patients that fit in here. And there are things we are trying to do to bump everyone from that sort of 35% group up to 85%, but it's been a bit of a slog and a struggle to do that. And I'm going to show you sort of 2 patients, 2 scans that look, technically in the same sort of stage, but obviously biologically are going to behave very differently. So here you can see on the scan, this person here has a mass in the kidney in the front here. And here's the back. This is normal kidney. Okay. Here's the IVC, the main vein. Okay. And so this mass is confined to the kidney, but it is larger. And when you take this out, this is going to show some small invasions into branches of the renal vein. So this will be a T3. Down below, you can see in this case, here's the person's left kidney. And there's not much normal right kidney left, just this little bit. And then they've got this big, ugly mass back here. And it's hard to see this vein because it's being pushed on by this mass. So this tumor is T3A2, but clearly this person above and this person down below are likely to have 2 different outcomes. This person above is probably going to do pretty good. This person down below, with the right treatments, may do well, but their disease is going to be more aggressive and they're going to need more treatment to get the same outcome as this person above. So it can be a very heterogeneous group when you start getting these medium large ones. So, there are some devils in the details, if you will. So when you look at these, basically what we're looking at is what we refer to as staging. And that's basically, staging is how physicians stratify patients to sort of tell them, okay, here's your chances of doing well, of doing poor, or doing okay. It's based on staging. And the treatments are also based on staging, right? So I'll show you sort of the normal paradigm for how treatments are decided upon in cancer cases. But the lower risk, sort of more localize your diseases, the more likely you're going to benefit from something like surgery. And when you get to a stage where your tumor has spread elsewhere, then you're going to really need systemic therapy, which in most cases is chemotherapy. So, how we stage people, you hear people say, oh, I've got stage 4 cancer, right? Those stagings are different for different types of cancer, but they're based on 3 factors. And those 3 factors are T, N, and M. So T is for tumor, N is for node, and M is for metastases. So in kidney cancer, the T stage, remember I talked about those small renal masses being less than or equal to 4 centimeters, right? When it's that, it's a T1A. Those patients do really, really well, right? With surgery, they're like 99% cured with surgery. When it starts to invade branches of the vein or it gets larger, then you start moving up to T2, T3. Those diseases are more aggressive, and so their outcomes may not be as good. In kidney cancer, the lymph nodes, they're either involved or not. In some cancers, it depends on how many are involved, but not in kidney cancer. It's just, is it involved or not? And then the metastases is, do they have metastases or not? It's important to realize that, someone has a T4 tumor, most stage 4 patients are not T4. Most are actually T3, but they have had spread somewhere else. So, if you have a T3 tumor, it doesn't mean that if you wait till it gets to T4, it's probably not going to spread. It will probably spread even before it gets to that T4 state. Okay. So as I mentioned, the traditional paradigm is, if you have localized disease, you're more likely to get surgical management. Then you get up with metastatic, you're more likely to get systemic, which is chemo. Kidney cancer is very different in many ways, and we'll talk a little bit about that, likely when we come to the question period. But if we, pause for a minute and think about the metastatic kidney cancer, these are patients who have had their kidney cancer and the kidney cancer has spread. Historically, we would have said the chance that you're alive at 5 years is only about 12%. Now that goes back to, maybe 1990s, 2000. And as mentioned here, things have changed and there's good reason for hope. So with the metastatic disease setting, with what were called tyrosine kinase inhibitors, this jumped up significantly. And we've moved on beyond that now to what's called immunotherapy. So it's gotten even better now. In a combination of using the immunotherapy plus these targeted therapies, plus or minus surgery or multimodal approaches, we see that patients actually do much, much better. Okay. And so, I'm going to show you this figure here. This is actually from the first study that led to immunotherapy being approved for metastatic kidney cancer. And the percentage of patients, alive at sort of 18 months, okay, on the study arm was 75%, with the regular treatment of 60%. Now, this is patients who are poor or intermediate risk metastatic disease. So it didn't even include the people who do best, who have metastatic disease at good risk. So these are kind of like the worst of the worst. And even in those patients, 3/4 of them are alive at a year and a half. And if you look at the median length of survival for patients in the immunotherapy arm, up here in the corner, it was not reached. So, they followed this study out to about 3 years, and still had not reached the median. So the vast majority of people who had the worst type of metastatic disease still were living much longer. So this 12% has really gone up significantly with these newer therapies. So kidney cancer treatment gets better and better, both localized, but also in the metastatic disease setting. So as I mentioned, we've got that traditional paradigm. In kidney cancer, there's a whole lot of things that we throw into the mix now, including surveillance. We have other treatments which are like surgery, but not as invasive. Those are ablative techniques where we may freeze it or we may electroporate it. We have surgery. Radiation is something traditionally we didn't use in kidney cancer. We had started to realize that used in the correct way can actually be very beneficial in certain circumstances. And again, these two things, the TKIs, which were the tyrosine kinase inhibitors, and the immunotherapies, we are using these a lot more now. We don't use chemo actually in kidney cancer. We use these systemic therapies. They're technically not chemo. Most people, even medical oncologists, will call them chemo when they talk to patients, but that's a misnomer. They're really systemic therapies. Their side effects are much lower because they're much more targeted and specific. And so, many patients on immunotherapy, for instance, can do many of the normal things that they like to do. Whereas, many patients on chemo do not have that benefit, right? Their quality of life takes a significant hit. The immunotherapy, certainly they can have side effects, but generally speaking, they are really well tolerated. So then question 4 then becomes, well, okay, we've asked, question 1, how do I educate myself? Question 2, where to go? Question 3, small, medium, large. Question 4 is, what are the treatment options? And these are just a couple, say, motherly statements, but some things just in general to keep in mind when it comes to treatment options. Almost never is there only one option. Okay, there are usually more than one option, despite it being small, medium, or large, right? Each of those options have pros and cons. No treatment has, all pros and no cons. If it sounds too good to be true, it probably is, right? They all have pros and cons, and how you select those and the individual patient You can optimize the pros while decreasing the cons, but it doesn't eliminate them, right? There are always still potential problems with treatments. Fancy treatments are not always better, right? Sometimes someone may have a mass where it hasn't spread elsewhere, but it's big enough that they can't have part of their kidney taken out. Well, then you should just, you can do a radical. But, one guy wants to do it robotically, another guy wants to do it lap. There likely isn't necessarily a benefit in that setting that they need to do it robotically. So just because it's fancier doesn't mean it's better. More treatment or treatment at all does not always mean better care. Okay. Treatment that is indicated and there's data behind and supported by sort of standard guidelines, it's what you want, right? If you have something that doesn't need to be treated and someone wants to go in and take out your whole kidney, well, that may not be the best thing for you. So more treatment or treatment doesn't always mean better outcomes or better for you. And then the other thing is, it's very common when we have small masses or medium masses even, where we may consider just taking out part of the kidney. That may not be the best thing. People, surgeons and patients alike worry about, oh, well, what happens if I take a kidney out and then I'll need dialysis down the road? In most people, if you have normal kidney function before surgery, whether you have part of your kidney or all your kidney taken out, the best data and evidence would say that it's not going to make any difference. Your risk of having dialysis is the same as the general population, very, very low. Okay, so those are just some things to keep in mind. When it comes to treatment options, it kind of depends on where you fit into that spectrum of small, medium, or large. So, the small renal masses, there's several. There's surveillance, ablation. You can watch these. They grow very slowly. If you're 85 and you've got a 2-centimeter mass, well, if you take the standard life expectancy and how fast these grow, and if I tell you the risk of them spreading is less than 2%, and it doesn't really go up till you get to, above 4 centimeters, maybe even above 7, well, if you watch it and it grows 0.1 centimeters a year, it may take 20 years before it gets to that point. And you may not plan to be around at 105. So, surveillance can be a good option for some patients. Ablation there's different ways you can do this. You can microwave it, or you can not your one at home, or you can use freezing. We use freezing at the University of Florida. It tends to work a little bit better. But this is basically done here actually by radiologists. They put a little needle into the back and they freeze the tumor and they create a little ice ball where the tumor is, and that kills off the tumor. Now, is it as good as surgery from a cancer cure point of view? No, but it's about 92 to 96% effective. So it's still A plus, but it's less invasive than surgery as well. So, someone who maybe does not want to have a surgery or is at risk for having a surgery, ablations can be a really good option for them. It can work really well. Surgery, there's all sorts of surgery. You can have open, lap, robotic. Generally speaking, for a small renal mass, most people are going to have a robotic partial where we go in and we take out part of the tumor. But there are cases, for instance, some patients have genetic conditions where they have lots of masses in their kidneys. And if I'm going to take out 7 tumors out of the one kidney, I'm probably going to do that open because I can hold the kidney in my hand and move around a lot easier without clamping it for as long. So in some cases, even in this day and age, open may be the right way to go. Just it depends on the patient. The other one is biopsy. This is underutilized in many countries in the world. Certainly in the US, it's underutilized. As I mentioned, 20 to 25% are benign. I think I'm pretty busy in life right now. My wife and I, we have 2 kids. Our youngest is only about 2 months old. I'm also busy seeing patients. If I had a small renal mass and there's a 1 in 4 chance of it being benign, do I want to go and have surgery and have it removed and have to go to time off work and being at home and trying to look at kids at home while I'm busy? I may not. If I do a biopsy and it comes back as cancerous, then maybe I do. But if it comes back as benign, then I can continue to watch it and feel comfortable doing that. So biopsy is something that's underutilized, but sometimes can be very beneficial to help us delineate, is this a tumor or not? The idea is that if you take most patients with small renal masses, right, as I mentioned, a good number are benign, most are indolent or lazy, and only a very small number are actually ones that you need to worry about. So if you look at all these patients with less than 4 centimeter renal masses, 100 of them, At 10 years, maybe 5 of the 100 may have passed away if you didn't do anything. So, biopsy can help us figure out which one of these groups you fit into and make sure that you're not one of these sort of sheep's hiding amongst, or wolves hiding amongst the sheep, right? That's who we really want to treat is the wolf. The sheep's, we can watch those and they're probably never going to do anything to you. So biopsy can be a tool we can use to do that. Most people, and even urologists don't recommend biopsies. If you look, these are the top 10 cancers in men and women. And if you look at this list, almost all these cancers are treated and managed initially by having a biopsy done. And the outlier to that is kidney cancer in both men and women, right? Of all these tumors, prostate, you get prostate biopsy. Colon, you get a colonoscopy. Tumors in the bladder, which I deal with as well, you get a scrape in your bladder first to figure out where you fit in. But we don't do that with kidney, right? And maybe we should, because we could start treating people who don't need it and then focus our attention and our efforts on the people who really need it. When you start to get to those larger masses, the question is surgery. Should you have a partial or a radical? Most times it's going to be a radical because it is a larger mass. How you have the surgery done, it depends. I've done some large tumors robotically, I've done some lap, I've done some open. There are different circumstances where I may want to choose one over the other. And your surgeon should be able to go through and tell you why those reasons are, right? You should, if you want to know about your disease, then you want to know, well, why are you doing this open or why are you doing it robotically, right? There's a reason why they're doing it like that. So, you should ask why that is. And then these larger medium ones, the question is, should you have treatment afterwards? And that was I wouldn't say a bone of contention or a sore spot. It was something that I think we felt like we had let patients down. I'm just going to show you a couple pictures here. This is what the robot looks like when you're having a robotic partial or radical. This is open, where they're cutting out just that tumor out of the kidney. These days of big incisions, when you have open surgery, are really not very common. Most times, if you have an open incision, it tends to be much smaller these days. These are not patients of mine. These are just pictures of people who've had kidney cancer surgery that are on the internet. But you can see, obviously, the recovery from this incision would be much easier than the recovery from this awful big thing. So, as I mentioned, the treatment after people have these medium, large, and have surgery, unfortunately, it wasn't a success story. We tried giving treatment before surgery, we tried giving treatment afterwards, and we really saw no benefit. And it wasn't for lack of trying. These are all these studies that were done historically with older types of drugs that didn't show any benefit. These were ones done with newer studies more recently that didn't show benefit. So this was a very an area where we really feel like we hadn't shown a benefit to treatment after surgery. And that creates a lot of problems, right? I mean, most patients want to do what they can to do the best to give themselves the best chance of hope. And we don't have anything to offer in the space. I think it led to a loss of empowerment for patients, and psychologically and from a quality of life, I think that had a significant impact. And I said, we were due for a game-changing study, and that actually happened about 2 years ago, November 2021. It's a checkmate study, and this showed with an immunotherapy drug that if you give it to patients who have these reasonably sized tumors after surgery, they actually did better. So many times, patients who have these T3 disease where it hasn't spread, we will recommend they go on immunotherapy afterwards because we know there's a benefit because of this trial. So this was a big moment for us about 1.5 years ago, and I think it's led to good things for patients. But it also highlights another point. The locally advanced and metastatic, it's not just sort of one treatment, it's multimodal treatment. And that's in any cancer these days. You're seeing surgery in people with more advanced disease than we used to. And we're seeing immunotherapy or chemo and things like that in people earlier than we used to. By using different types of treatments in certain combinations, we can get better outcomes for patients without impeding their quality of life. So I just want to spend a little bit on the systemic therapy in kidney cancer. Most cancers are treated with chemotherapy. Chemotherapy is kind of like a nuke, it kills everything, right? The good stuff and the bad stuff. And that's why a lot of people get toxicities with chemo. You know, your guts, right? Diarrhea and nausea is a very common one with chemo. And that's because the cells in your gut are one of the more rapidly dividing cells, just like cancers. They turn over quickly, and that's why chemo works on cancer cells, but also why it gives you problems with your gut when you're on chemo. These drugs, both the targeted therapy, the TKIs, and the immunotherapies, are much more like a smart bomb. The TKIs go in and they affect these sort of signaling pathways that we know kidney cancer cells use. And the immunotherapy goes in, and your tumor has a way of hiding itself from your immune system. And the immunotherapy goes in and it allows your immune system to be able to recognize those cancer cells again. And your immune system then goes in and takes care of the tumor cells. And that's why it works so well when it works, because it's your own immune system. Your own immune system knows how to get into every little nook and cranny in your body and eradicate the cancer. So these therapies tend to have lower side effects. Some of them are actually oral, some are IV, but they tend to be better tolerated and work better than what we used to use for kidney cancer. So it's just important to know about kidney cancer. So specific questions, you know, I'm a urologist. Some of you will see urologists, some of you will see medical oncologists. A few might see radiation oncologists or radiologists. The specific questions I would ask when you see urologists is, you know, what are the pros and cons of the different management options for your disease, right? How do they plan on doing the surgery if you're having surgery? Open, laparoscopic, and why, right? And, you know, are you having a partial, are you having a radical, and what's the thought process behind that? I think anytime you want to have surgery, you want to know, you know, what's length to stay in the hospital, but also what's the recovery time when you go home, right? You know, you shouldn't expect to go back to lifting heavy things the next week if you work, you know, a physical job. And they should educate you on that so you know what to expect. It will set you up for success and decrease your rate of complications. The other thing is, what's the risk of having kidney failure or kidney dysfunction afterwards? In many cases, most patients assume it's going to be more significant than it is. Most times when we do these surgeries, we're actually not going to impact your kidney function a great deal. But if you don't ask, you won't know that. So ask that. And then, you know, what are the alternatives to the treatment option they're proposing? Particularly for small renal masses, there are a lot of different ones and almost all of them work well. So, you know, what are the other alternatives? There are always alternatives. And then when you come to the larger masses or people with metastatic, how do you sequence the different types of treatments, whether that be immunotherapy, surgery, or radiation? How do you sort of mix and match those, and in what order do you do those? Because that can be important in some cases. In other cases, it's less important, but it's good to sort of have that discussion up front with your provider, because it will sort of set up the framework for what's going to happen in your mind. You know, it may be that I'm going to get immunotherapy for 3 months and we're going to repeat the scans. And if it looks good, then we may do surgery at that point. So at least it allows you mentally to prepare yourself for, you know, what's your treatment plan going to look down the line. So I think I'll finish there, and that will give us plenty of time for some questions. And I'm happy to take any and all of those.
Wow. Thank you so much, Doctor. That was a wealth of information. We did have some questions that people had put into the social media, and that you answered every single one of them, with the exception of a couple that were probably a little more advanced. But Tracy's on the call, and I'm sure she can ask those that now if she has any questions. So if you do have questions, feel free to unmute yourself, and you can ask them here, or you can type them into the chat, and we'll make sure to get
Scott. There's one in the Tracy. There's one you put in the chat.
Yeah.
You know, are these statistics for clear cell and non-clear cell?
Yeah.
So, you know, clear cell is, like I said, 75% of most kidney cancers are clear cell. So most of these stats are for clear cell. They can be better and they can be worse depending on what subtype you have. So, for instance, you know, the chromophobe renal cell carcinomas.
That's my subtype.
Yeah, so many patients with chromophobe actually do better, okay, than clear cell, right? Because it tends to be less aggressive. There are a small number of patients who have chromophobe that don't behave like that and tend to be a little aggressive. And those ones can be a little trickier, right?
Yeah.
Yeah. And the other thing is, that has implications not just from the surgical point of view, but also from the systemic therapy, right?
Mhm.
Most of these studies, okay, were done in clear cell patients, right?
Okay.
So the immunotherapy, for instance, most of the data for that is from clear cell patients. And you can look at it two ways, right? You can look at it and say, well, that's great for clear cell patients, but it kind of screws everyone else over if non-clear cell are not in the trial, right?
Right.
That said, if you put everyone in a trial, what may happen is you may not pick up that it makes a benefit,
Right.
right? Then no one benefits. So it depends on how you look at it. It's a glass half empty, half full. But what is happening more now is that we are seeing a bit more data on non-clear cell types and immunotherapy and other therapies, and that's coming. It's just a little slower, unfortunately. I will say, in some of the more aggressive types of renal cell carcinoma, like sarcomatoid and rhabdoid, medical oncologists were very loath to use the immunotherapy because they knew these were aggressive and they didn't know what would happen. Most of the data shows that the immunotherapy probably works better. So I think it'll take time, but eventually I think you'll see a
Right.
lot of people will end up with immunotherapy regardless of their subtype.
As and are you referring to that for adjunct or like for the more advanced stages?
For metastatic, we'll see that
Metastatic.
first, and then like everything else, it'll move earlier. But for
I
small masses, they won't
right.
do that. For the medium ones that are like T3s, where there's a
Yeah.
risk of it coming back. So there are, as I said, that's a spectrum of patients, right? And so what I normally do when I have patients in that, when this study came out, we kind of said, okay, if you have T3 disease, you should go and get immunotherapy.
Yeah.
Some patients in that group are higher risk than others. And so
Right.
what we do now, I send them to talk to the medical oncologist about it, but I always talk to the patients about it because, the immunotherapy is well tolerated, but it does still potentially have side effects.
Mm-hmm.
So one thing we do is that there were previous studies done, particularly in clear cell, on patients with T3. And one of these trials is called the ASSURE trial. And one of the things that came out of it was this risk calculator where you can actually put in, there's a couple subtypes. I think chromophobe may be listed on it. I have
Okay.
to double check. I know papillary is, I think chromophobe is too. So you
Okay.
take the age of the patient, the size of the tumor,
Right.
the stage, the grade, the subtype, and there are some other features like sarcomatoid or necrosis. And you can plug all those numbers in. And what it gives you is a prediction of what your risk of disease recurrence is.
So
Okay.
for chromophobe, I have a question.
Yeah.
We do not get graded.
Yeah.
I'm sorry. So we would not be right. Some have the I guess it's the staging and then the grade, but with chromophobe, is that not graded the same way as clear cell or not graded at all?
So it's a little tricky and it depends on the pathologist.
Okay.
They used to not do it, and then they used what was called a Furman grade for clear cells.
Okay.
Now it's they've kind of changed it a bit where they use an ISUP grading system 1 to 4, and so those some places they will report it and some they won't. Yeah.
Thank you.
But
Thank you.
what you can do is if you're sort of say, okay, I'm chromophobe and I'm not sure, then you could put it in sort of as grade group 3, right? Because that's
Great.
probably going to be the most common group, right? If it's
Great.
learned. So
Okay.
I will let me just do something here, for instance. Give me
I
one.
I am currently stage 3 with invasion chromophobe, but I'm a little bit more of a unicorn because I did genetic testing, which I know is a whole nother topic. I won't
Yeah,
go into detail, but I have somatically the SDHB mutation as well as the PT53. And so I've been on active surveillance for 2 years and now I have bilateral.
yeah,
Um, so I guess my question would be, since I feel like I've been uh, newly diagnosed again, it's quite shocking. You mentioned that a partial isn't always the best foot forward. My new growth, it's under a centimeter, is now, I'm sorry, is located mid-inferior on my remaining
Yeah.
kidney, but my GFR is still pretty strong, around 50, 2 years post-op from my full. What other options? I think that would be a second primary, not, is that correct? Okay,
Yeah, it's so you probably, because you have a somatic mutation, you probably have a new lesion, right? And
right.
so there are some guidelines on sort of when you should have those resected, right? So people who usually have genomic symptoms, you wait till the largest mass is 3 centimeters, and then you take all of them out. Now,
Okay,
there
thank you.
is some flexibility with that. I mean, if you had a mass that's right in the middle of the kidney where a lot of the important structures are, it may
Yes.
be prudent to do it sooner rather than later, right? When it is still resectable, right? Uh,
Okay.
but that's, person to person. And the thing is, you had genomic testing done, right?
I'm a patient of NIH and Lombardi, so I am with both with NIH, and they're currently studying it. Yes. So
Yeah.
P53 was germline only. I'm sorry, I'm getting that confused. The SDHB was germline, and then did the somatic. It was in addition, I had the 53.
So what she's talking about for those others on there is that germline is sort of and somatic. One is sort of in your tumor, and the other is sort of what you were born with, right? And so
Right.
some people have an inherent risk because they have a genetic condition that makes them prone to these things, and then they can have additional mutations in the tumor, which is why the tumor sort of came up or started to develop it. For many of those patients, not all, I mean, we see a large number of genomic patients here, but certainly the leader as far as genomic kidney cancer in the United States is NIH. Marcin Linehan is the gentleman there who's done really a lot. He's a great speaker and really has done the lion's share of sort of promoting the work on genomics in kidney cancer, and sort of discovered that most of the genes involved are actually all in the sort of metabolism, your glucose metabolism, which it's really fascinating. But yeah, so I mean, you're in good hands there, right? Obviously, with them for that. Yeah.
My main concern would be if I had to have another partial. What does that look like for a newly diagnosed second time?
Yeah, I mean, every time you have a surgery in your kidney, it doesn't help it, right? There are different things you can do to try and optimize that, right? So how long you have your kidney clamp for, right? You know, people think that makes a difference. NIH does something interesting for genomic people. They do it and they don't clamp, and they just cut it out. Now, I don't know if I agree with them on that, because the problem is that it bleeds a lot.
Okay.
So, for some patients who have 6 tumors, they're going to get transfused. And
Right.
that's not always good for your kidney function either, just when your blood pressure gets low because you're bleeding. So, it's a work in progress, I think, but they do a lot of those. But if you just have the solitary one, or even two, I wouldn't expect it to make a big difference as far as your kidney function. Yeah.
Okay, great. Thank you, doctor.
Yeah, no problem. Any other questions?
While anyone's thinking of questions, just a couple of announcements. We will be having, first off, if you missed any part of this recording, it will be put up on our website and our YouTube channel by April 10th. So we'll have that for you there. And then also, we have a symposium coming up with UF Health at the Hilton UF Conference Center on Monday, May 15th, 2023. And so Dr. O'Malley and his colleagues will be talking about everything from kidney cancer 101 to palliative care. So if you are in the area, please join us. You can register on our website, and we'd love to see you there. I think that may be all the questions for today, Dr. O'Malley. You did a great job of presenting and got everyone's questions answered.
Super. Thank you, everyone. Have a great rest of your week.
Tracy says, thank you. Thank you so much, doctor. You have a great day. Bye, everyone.
Bye for now.